So hello, everyone. I'm Philip Payne. I'm the Associate Dean and Chief Data Scientist at the Washington University and St. Louis School of Medicine, where I also lead our Institute for Informatics, which is our home for informatics research, education, as well as practice throughout our health system. So one of the big challenges that we see in healthcare is that we often have a wealth of data that we produce, but we don't always access that data and use it in a timely and efficient manner. And this applies across a pretty broad spectrum, from how do we design and conduct research studies to how do we educate future innovators and practitioners and leaders. And perhaps most importantly, how do we deliver high quality, safe, efficacious, valuable care to patients and populations? And one of the challenges that exists right now is a essential imbalance between our goals of protecting privacy and confidentiality, and then the lack of appropriate tools and technologies that allow us to do that while also making data a democratic asset, something that is readily available to everybody in our organizations across all of those mission areas. And so when we first learned about MDClone and synthetic data, we realized that this was a highly scalable and extremely high impact solution to those problems, because we were able to take all of that data that we produce every day, turn it into a format where it was much more readily shareable while maintaining the fidelity and the completeness of the data in a way that previously wasn't possible. And then couple that with tools that allow us to put the data in front of the right people at the right time and place. And I think that's the other important theme. How do we make sure that we don't have to have technical professionals or informaticians or data scientists as human mediators to data? How do we make data readily accessible when people need it, how they need it, so they can ask and answer questions very quickly? So when you take that combination of being able to share data safely and protect patient privacy and confidentiality, but without losing important signals in the data, and you empower those end users to actually access data when and how they need it, that is the unique combination of capabilities that MDClone gives us. And especially in an academic health center, but more broadly, when we think about transformation in clinical care and the delivery of population health, these tools are only going to become more important over the coming years and decades. So we've been able to use synthetic data in a lot of different scenarios. I'll start with some of the original research projects that we undertook when we first evaluated MDClone. And these largely centered on how could we combine data across multiple sources in our enterprise, including telemetry from the bedside, electronic health record data, and other social determinants or environmental features, and be able to ask and answer questions such as, can we anticipate volume or demand in our children's hospital, especially for children suffering traumatic injuries? And can we adjust our staffing or care delivery models to anticipate that? Or how do we do a better job of anticipating who in general units in the hospital may become sick with sepsis within an 8 to 10 hour window so we can intervene before they end up in the ICU? And we've also used that to look at more social and population health level drivers of healthcare utilization. For example, predicting things like STD rates or gun violence, again, that impact activity in our emergency rooms. And the really exciting thing about all of those research projects was that we were able to do that with multiple types of data that previously had not been easily combined into a single repository. We were able to put that data in front of people literally in minutes, as opposed to taking hours or weeks with complex manual de-identification and regulatory review processes. And we were able to empower our clinician scientists, our students, our research staff to ask and answer these questions in the MDClone environment without having to use specialized data scientists, informaticians, biostatisticians, other technical professionals. So this really sped up the research process and also allowed us to iterate on those research questions very quickly. And as we think about sort of the advent of machine learning and other cognitive computing methods, that ability to query data, build a model, evaluate it, and then optimize and repeat quickly, that's the workflow that individuals expect. But our traditional ways of delivering data in the healthcare enterprise for research don't really support that. So again, MDClone provides a unique solution there. And then if you sort of scale that up to other parts of our enterprise, we now use synthetic data in most of our coursework around informatics and data science. We've actually just embedded that into our medical school curriculum as part of our new Gateway MD curriculum. But we also have master's, PhD, and postdoctoral programs, as well as more in-career focused practical training, all of which leverage this synthetic data so that our students aren't working with hypothetical data sets. They're working with real data sets that have been extracted from our care delivery enterprise, which means the skills that they learn in the classroom can be quickly translated into applications in the clinic, in the lab, in population health settings around Washington University with our partners at BJC and the broader St. Louis area. And then I would say sort of at a national scale, we've been fortunate to be able to lead a number of large scale projects to employ synthetic data to enable multiple health systems to combine their data so we can do large scale benchmarking or comparative analysis studies. And probably that is no more evident than during the COVID pandemic when we were able to build one of the largest synthetic data sets that we have ever had the opportunity to work with as part of the National COVID Cohort Collaborative or N3C program under NCATS. And there again, by using MDClone, we were able to democratize access to this data. So citizen scientists, industry-based researchers, international collaborators could share in these data assets in equal measure to more traditional academic investigators. But I think across all those examples, the theme is really speeding up access, addressing privacy and confidentiality, and having the right tools so we can disintermediate that data, really put it in front of researchers, students, policymakers, decision makers in a way that doesn't require a lot of specialized technical expertise.